Hello, everyone, and welcome to my presentation today. Thank you very much to the organizers for inviting me to give my presentation of my work here today. My name is Ben Kuzma, and I'm currently a postdoctoral fellow at Harvard Medical School and Mass General Hospital. The work that I'll be presenting here today is the work that I did during my PhD at Long Island University. And today I'll be talking about the dermal disposition of metronidazole and the development of a level A in vitro and vivo relationship for topical dermatological drug products. So first things first, I need to start off with the FDA disclaimer that the views here are my own and they don't represent anyone at the FDA, at the US FDA. So let's kind of start off and say, kind of why do we care about doing an in vitro and vivo relationship or the dermal disposition of the drug products? So as we know, in society, the drug products are quite expensive. So brand name drug products take quite a long time to get to market, 10 to 15 years, and they're also quite costly for the drug company themselves, which eventually gets passed along to the consumer. Now, generic drug development also reduces this price of the drug products. So when a generic drug product comes to market, the brand name's drug is now off patent, and this significantly drops the cost of the drug product, and also then that's passed along to the patient. Now, if we look at topical dermatological drug products, most of them don't have a generic, which is why a lot of the therapeutics or therapies are very costly to the patients, and this often relates to low compliance, people just stopping to take their medication just because it's very expensive, and that's one of the reasons. But by developing these generic drug products, then we can significantly lower the price of topical therapies for patients across the board. So as we can see here, more than 50% of topical drug products had an increase in price from 2010 to 2015 by over 300%. So we definitely need to address the generic topical dermatological drug product kind of shortage. So very quickly, I'll get into the skin structure. Now the skin structure, as we know, is made up of the kind of the three stratifications, if you will: the stratum corneum, the epidermis, the viable epidermis, and the dermis. So the stratum corneum is mainly thought of as the barrier to xenobiotics, to getting into the skin itself. So the formulations have to basically circumvent the stratum corneum in order to get to the site of action. Site of action for many drug products is the dermis. So we need to be able to get the drug out of the formulation and eventually into the dermis. And as you see here on the right-hand side, you have the different routes of permeation here. You have 1 and 3 are really trans-appendigeal, and then 2 is the intercellular, intracellular route of penetration or permeation. And this is just a very simple cartoon of the skin. Now we obviously know it's much more complex than this. So now, if we want to look at the dermal disposition of drugs, typically what we can use is microdialysis, or we can even use open flow microperfusion. In this case, we're going to be using microdialysis sampling. So what we have in microdialysis sampling is basically a concentration time profile. So we basically see the relative appearance and disappearance of drug. Now, there's really no way to separate out the absorption and the disposition functions from one another if we're just measuring the concentration time profiles. So again, if you will, with this cartoon, we have the drug, the API and topical formulation, eventually has to go through the stratum corneum and traverse its way into the dermis. Now, with microdialysis sampling, we don't have experimental data on how these processes are occurring. With other techniques, we may have some more information on how these processes are occurring, but for this specific dermal microdialysis methodology, you don't have information from the experiment about these processes. So now when we look at dermal microdialysis sampling, what we have is we're only looking into the dermis, and we have our observed concentration time profiles. And as you see here, you have a typical dermal microdialysis concentration time profile. And then what we also don't know, as I mentioned before, we don't know how the drug is eliminated. So when we look at microdialysis concentrations, or even systemic concentrations for that matter, we know that the plasma, or in this case, the dermal concentration time profile, is a result of an absorption function and a disposition function. And the combination of these two leads to our concentration time profile. And we'll be seeing this, I'll be reiterating this quite a bit over the course of the presentation. So now, as I said, as you had seen before, you have your dermal concentration time profile, the right here. So now, how do we look at our absorption function, disposition function? How do we kind of get this? So for our methods in dermal microdialysis, we don't have, as I said before, we don't have information about how the drug gets out of the formulation into the stratum corneum, and then eventually into the dermis. So for our sake, we're going to call this our absorption function. Now, with microdialysis, you only have the unbound drug that you're measuring. You don't have the bound drug. So these processes, as we know, are also equilibrium with other processes. So, right, you have the drug that's in the cell that's membrane bound. You have the drug that's in the cell. You have the drug that's also protein bound to various things within the skin. And then you also can have the possibility of the drug being metabolized. Now, these processes are the distribution of the drug, or the API, within the dermis. So now we also have how the unbound drug is cleared. So for the most part, the drug is cleared by the blood into the subcutaneous tissue by passive diffusion. And now we have these as our elimination. So now we have our distribution within the dermis, we have our elimination, and this is our disposition function. So the definition and the use of a disposition function is essentially, I'm sure many of you are aware of these, but just to reiterate, it's basically the concentration derived from a unit amount of drug. So you deliver 1 unit of drug, what is the expected response for the distribution and the elimination of drug? So now in systemic PK, what we have is usually they use IV bolus or IV infusion, and this obviously just bypasses the absorption step. There's no absorption. So you have just the distribution of the drug and the elimination. And the way that we can use this is we can convolute our unit impulse response by our in vivo or in vitro dissolution profile, and then we can predict our in vivo plasma concentrations or in vivo dermal concentrations, if you will. Then you can also use the unit impulse response to deconvolve the plasma concentration profiles or the dermal concentration profiles in order to get an in vivo absorption profile. So very quickly again, I know many people here are very familiar with PK. We have IV bolus, so basically delivering the drug, and this is responsible for just the distribution and the elimination of the drug. So we deliver the drug, one time point, and then we have a first order elimination, and this is represented by our C is equal to C0 e to the minus KT. And as we've seen this before, we have our plasma concentration is the result of our input function and our disposition function. So what are the typical uses of a unit impulse response in an in vitro and in vivo relationship? Here you see you have your in vivo dissolution, and you use that unit impulse response to get your predicted PK profile. And then you can also have your fraction absorbed curves, and then you have your dissolution profiles, and you make some sort of in vitro and vivo correlation. Now, in drug development, we have PBPK models. So this is kind of come to the forefront where a lot more of this has been used. And this really is useful because it can understand or can kind of predict the absorption parameters. And that's really sometimes the rate limiting step for many drugs getting into either the systemic circulation or into the dermis or the site of action. Now, the part of the body that's really part of this is related to the disposition of the drug. So now we have PBPK models, and you're modeling the absorption. Now, how do you get the disposition of that drug? Well, we can still use kind of empirical models to get this volume of distribution and clearance and the elimination rate. And these really help to improve this PBPK model, where now you are not really estimating these different parameters, and now you have these parameters set, and now you can focus on the absorption of the drug and really focus on that. So in my personal opinion, you have PBPK models, you have empirical modeling for IV-IVC, and essentially they are really working together to get to the end result, which is hopefully a very good predicted IV-IVC or IV-IVR. So how do we estimate our dermal disposition function in the dermis? So what we can do, so as I mentioned before, the disposition function is the distribution and elimination of drug. So now what we need to do is we need to deliver the drug directly into the dermis and then measure the concentration there and then look at the elimination of the drug independently of a topical formulation. So what we can do is use a microdialysis probe and we can deliver this directly into the dermis. So as you see on the right-hand side here, the top part is the delivery of drugs, right? So you have the drug, which is represented by the green circles there, and the drug is in the perfusate. It's being delivered into the interstitial fluid, which of course is lower concentration than the perfusate, which then in turn the concentration goes out and then eventually equilibrates with the surrounding tissue. Now the other processes that you have is the recovery of drug. It's typical of microdialysis where you're just recovering the concentration that is surrounding that microdialysis probe. So this is what you'd use for topical drug delivery, or what you could use for topical drug delivery. So now our study design in order to get this disposition function is you insert a probe that's pretty far away from the formulation application sites so that there's no lateral diffusion of drug that's applied on the skin, or you have any systemic redistribution. Here on the right-hand side, you'll see a very theoretical profile of what we would expect to see for a dermal infusion. And that's what we'll be referring to this as, where you have a delivery phase for a certain amount of hours, where you need to make sure that you're at a steady state concentration for a certain period of time. And then you switch the perfusion solution such that the drug is no longer being delivered, and you stop this infusion, if you will. And then you have an elimination phase where you basically can see the drop off of drug from that original steady state concentration. So you keep sampling, then you plot the data and analyze and take a look and see what it looks like. So now, how would we do this? Well, what we do is we have our theoretical profile here on the right-hand side, and you'd identify your steady state concentration, the CSS here. Then you would measure the area under the curve from that specific steady state area, our shaded area here, from T1 to T2. So now we can also calculate our dose here. So we know our concentration in the perfusate. We know our concentration that's at steady state. We know the volume that we've perfused. So now we calculate our dose. And now that we have dose and we have our AUC from T1 to T2, we can now calculate the clearance. And this is kind of the information that you can get from your delivery phase of this dermal infusion or even IV infusion. So now when we stop the dermal infusion, now we have our elimination phase. So basically what we can do here is we have our clearance already. Now we can estimate our KE from this slope here, as this would be a mono-exponential decay, estimate our KE, and now we have our volume of distribution. Now this becomes a little bit more complex with the poly-exponential decay, but for now, for simplicity's sake, we'll just stick with mono-exponential decay. So now we have our dose duration studies where essentially what we were doing was applying a topical formulation for different doses, different dose durations with 6 hours, 12 hours, and 48 hours. We had two topical products, a generic metronidazole cream and a generic metronidazole gel. We applied these at a dose of 10 milligrams per centimeter squared. And we have our dermal infusion probes here where we perfused the microdialysis probes with 0.4 microgram per ml of metronidazole. And after 10 hours, we switched it to 0.02 deuterated metronidazole. This is just to basically use as a correction factor for the difference in recoveries. So now what we can see is that we have an adequate characterization of our dermal pharmacokinetics. So here we can see the cream on the top and the gel on the bottom. For our dose durations of 6 and 12 hours and 48 hours for the gel, they're more or less overlapping. There might be a slight enhancement in the permeation at 6 hours for the gel, presumably due to the formulation removal. And if we take a look at the top of the cream there, we see the 12 hours and 48 hours, very similar, overlapping. And we can see that the 6 hours was delivering less drug than the 12 and 48 hour dose durations. So now as I mentioned before, we have our two dermal infusion probes and 3 Yucatan mini pigs. So we have a total of 6 probes. And as you can see, these are the individual profiles on the right-hand side here. And we perfuse the drug for 10 hours. And then we switch the perfusion solution indicated by the red arrow there. And then we can basically just plot these and we can get our disposition function. Now, if we take a look at the topical formulation and we take a look at the dermal infusion here, what we can see, we plot these two next to one another. We have a dermal infusion similar to IV infusion, as I mentioned before. We plot these one on top of another, and we can compare these. We can see that the elimination from the dermal infusion is much faster than the topical administration. So what does this tell us? Flip-flop pharmacokinetics within the dermis for this specific formulations of metronidazole. Now this is pretty crucial because for a long time it's been hypothesized that this is actually flip-flop PK. We've really demonstrated that here. So now we have our dermal infusion probes and we're able to estimate our disposition function. So moving along to our IVIVC, what we have here is our IVIVR. What we have in IVIVC is a predicted mathematical relationship between an in vitro property and an in vivo response. Now, in my personal opinion, IVIVC is essentially plotting X versus Y and seeing if there's a correlation. And IVIVR is plotting X versus Y, but you may do some mathematical manipulation to either X or Y in order to have some sort of relationship. So for the purpose of the rest of the talk, I'll be saying in vitro and vivo relationship. So now what we have here is our in vitro, for our dermal IVIVR, we have our in vitro cumulative amount. We have our in vivo absorption profile from our dermal unit impulse response, and then we can make our in vitro and vivo relationship. Now you'll notice that the in vivo profile, absorption profile is on the bottom, on the x-axis there, and then on the y-axis you have in vitro cumulative amount. And for me, for this reason, is because I will be time scaling the in vitro time to in vivo, as y is typically the predicted parameter. So very quickly, this is kind of the workflow that I had when I was developing this in vitro and vivo relationship, where I was estimating the dermal unit impulse response, deconvolve the dermal microdialysis data, then I take a look at the data using a Levy plot and say, does this need time scaling? Yes, no. Maybe it's nonlinear, maybe it's linear, maybe I don't need it. And then do we need a permeation scale? Now we are using 2 different types of skin from 2 different labs. One's human skin, one's pig skin. So this could be a reason that we would need a permeation scale. Then we convolve our dermal unit impulse response with our in vitro permeation testing data, cumulative amount, and then we can evaluate our prediction errors for our in vivo dermal concentrations. So now we have our, as I mentioned before, we have our dermal disposition function here on the right-hand side. I've shown these 2 plots before, and now what we can do is very simply from the data analysis that I had mentioned in the beginning, what we can do is we estimate our elimination half-life from our slope here. Then we can calculate our dose. We picked 5.5 to 9.5 hours based upon our, it should be about steady state from 4 to 5 half-lives. And from 1.47, about 5.5 hours is about 4 to 5 hours. So now we calculate our dose, our volume and distribution, and our dermal clearance. So now we have these parameters, we can move forward and look at how do we calculate our unit impulse response. Well, we have a typical unit impulse response for a mono-exponential decay is just 1 over volume and distribution, e to the minus KET. Where here, our volume and distribution has units of milliliters, and elimination rate has units of hours to the minus 1. So now what we did, we averaged all of the unit impulse responses from all of the probes and all the subjects, so 6 total, just taking the average of that, and we have our unit impulse response of 10.1 times e to the minus negative 4.7 t. So now we can use this to deconvolve our dermal microdialysis data to get the in vivo absorption profile, or we can use it to convolute in vitro permeation profiles. So when we use this to deconvolve our dermal concentration profiles, we can see our in vivo flux. So here on the bottom, you can see cream on the left and gel on the right. And we have very similar basically patterns for the 6 hours, 12 hours, and 48 hours that we saw for the concentration time profiles, because the unit impulse response is just a very static thing, where if this is the same across the board, then obviously the only thing that should be changing across the concentration time profiles would be the absorption of the drug into the dermis. So as I said previously, we did see a significant difference between the 6 hour and 12 hour and 48 hour for the cream, whereas we didn't really see a significant difference for the gel. So now the question becomes, we have our dermal microdialysis data, we have our in vivo cumulative amount and in vivo flux. How do we relate in vitro permeation testing data and dermal microdialysis data? So this is one that kind of took a little bit of thinking, kind of figuring out, well, what's the difference? Why is there so much, why is in IVPT data in micrograms, and why is dermal microdialysis data in nanograms or even picograms for that matter? So if you take a look at the study design or the experimental setup, what you have is an IVPT data. You have dose applies 10 milligrams per centimeter squared. Your delivery area is 1 centimeter squared. Now with IVPT data, you have a Franz cell. And this Franz cell has basically a reservoir at the bottom where it's in contact with the receiver solution. The receiver solution is in contact with that entire application area. So all of that receptor solution is in contact with the skin and therefore the drug. So you have much higher concentrations of drug because you can see a much larger area. So now with dermal microdialysis, now you have, let's say we have a delivery area of 4.9 centimeters squared. Okay, it's bigger than in a Franz cell. However, you have a microdialysis probe that is 17 millimeters long by 4 millimeters wide. So now the effective area that you can actually see, if we want to compare this to the receiver solution, the actual area that you can see with this microdialysis probe is 0.068 centimeters squared, which is significantly smaller, which is about 15 times smaller than the IVPT data. So there's clue number one. Now we need to know that we need to normalize by the basically the area in contact with the formulation. So here, IVPT data is just divide by 1 to get centimeter squared. And whereas for dermal microdialysis, we need to divide by 0.068. So really, like I was saying before, the dose seen here is about 7,500 nanograms of metronidazole, where for the microdialysis probe, you see 510 nanograms only on that, just basically right down on top of the application area where the microdialysis probe is. Now you may say, well, there might be some lateral diffusion of drug either left or right, but in my opinion, these essentially just cancel each other out, because if you're laterally diffusing over 1 millimeter, it's also going to be diffusing 1 millimeter on the other side. So essentially, these lateral diffusion processes cancel out. So now our next step is to look at our fraction permeated and compare these. So here we have a Levy plot where we have the in vitro data on the x-axis. You have the in vitro data on the y-axis, and here we have the cream on the left and the gel on the right. And you can see that it takes a little bit longer, I would say actually a lot longer, for the same fraction to permeate in vivo than it does in vitro. Then you see about at around 24 hours, they about catch up, the in vivo catches up with the in vitro, and then it's fairly linear after that point. You can see the R-squareds here fairly good, and the slope is very close to 1, but if you visually look at this, you can see that there's definitely room for improvement. So now I'm thinking to myself, do I need time scaling? Well, yes, I definitely need some sort of time scaling. Now I tried a simple linear time scale, didn't work. So I've basically looked through the internet, looked through all the publications, and then I came across this article by Karat et al. Where he used this nonlinear time scale where he used an inverse release function. Now, inverse release function is essentially a dissolution profile. You have this dissolution profile. Basically, you take the inverse of it. So if your in vivo absorption profile is closer to a Weibull function or a Hill function or a double Weibull or a double Hill function, then basically you just take the inverse of that. And by taking the inverse of that, you can then time scale your in vitro time to your in vivo time. And when we do this, we can see that we have pretty good slopes for both of them, very close to 1. R-squareds also very close to 1. But visually, you can see that this is a lot better than what it was before time scaling. So now we have time scale data. So now if we take a look at the cumulative amount, we can compare these two. We have cream on the left and the gel on the right. In blue, you have your in vivo cumulative amount, and you have, in red, you have your in vitro cumulative amount. So now if you notice, in vitro is micrograms, whereas in vivo is nanograms. So these profiles look like they essentially overlap one another, but they're just off by a factor of 1,000 here. So what we need to do is do some sort of permeation scaling. So now we see, okay, we do need some sort of permeation scaling. And essentially what we did was we took the relative ratios between the cream. So we took the cream in vitro divided by the in vivo. That was about 1.6 times. And then we have our same thing for the gel. And now we took the average of these, and that's about 1.75. So we use 1.75 as our permeation scaling factor. We did try to use, like I said before, we tried to use the 14. And that was the difference between the areas, but we had already normalized for that, so that did not work out. We also looked at the skin thicknesses to see if there was differences. Maybe there was a correlation there. It's fairly close to 1.7, so there could be a possibility as to what we're scaling for, but again, this is only one set of studies that we definitely need to continue to do to validate this approach. So now we have our time scale data, we have our permeation scale data, and it's normalized by our application area for the dermal microdialysis probe. And now we can see visually, this is a fairly good in vitro and vivo relationship, where you can see that the cream AUC and Cmax is very close to the observed data. Whereas for the gel, it looks like it's a little bit over predicted for the Cmax, and the terminal phase there is a little bit over predicted as well. So that's something that needs to be investigated a little bit more to try and refine this model. But we got pretty good prediction errors where we have AUC 0 to 36. Now we did AUC 0 to 36 just because the animal's vital signs started to deteriorate a little bit around 36 hours. So we decided to just use that 0 to 36 as another parameter. We also used AUC 0 to 48, and you can see that both of these are fairly good, and these are less than the FDA guidance. And then we have our Cmax, which is above the FDA guidance for in vitro and vivo relationship and the predictability of that. So what we would need to do, it's above 20%, so we would need to do external validation. So now we were going to do an external validation, but we didn't really have a data set in order to validate this. So if we were to kind of continue on with this and really demonstrate the predictability of this model, we would basically do 3 milligrams per centimeter squared, 10 milligrams per centimeter squared, 30 milligrams per centimeter squared, and then basically see how well it can predict those different dosage. Yeah, if it can, wonderful. If it can't, why not? What is the kind of the problem with this methodology? So in conclusion, what we have is by using this dermal infusion approach, we were able to independently estimate our elimination rate, the volume of distribution, and the clearance, so our disposition parameters. So we also were able to demonstrate that we have a flip-flop PK situation with topical dermatological drug products containing metronidazole. And we were also able to estimate our unit impulse response by our dermal infusion probes. And by using this, we were able to characterize the in vivo flux and in vivo cumulative amount permeated. And so we were able to basically compare this with our in vitro data and develop this IV-IVR. And by normalizing by our dermal microdialysis probe area and what the probe can actually see, if you will, this can really facilitate a proper comparison between in vitro and in vivo data. And by using this nonlinear time scale, we were able to get a reasonable in vitro and vivo relationship in addition to our permeation scale. Now, as I mentioned before, unfortunately, there was no external data set for us to validate this with. However, we would certainly look into doing more studies with this. So I'd just like to acknowledge my advisor, Dr. Grazia Stagni, Dr. Shadare Senamar, for her help with all this work, as well as many other lab mates, Dr. Murthy at the University of Mississippi for very nicely providing us with the in vitro permeation testing data, and of course, the folks at the FDA who have collaborated extensively on this work and have been wonderful to work with, and it's been great to exchange these scientific discussions across the board. Dr. Sam Rani, Dr. Tanaz Ramazelli, and Dr. Priyanka Ghosh. And of course, I'd like to acknowledge the grant support from the US FDA with this work. And with that, I will take any questions that you may have. Thank you very much.